All right, Nick. So it's July again, which is a very exciting time because we know that this means that there are new incoming residents to OBGYN.
Absolutely. Brand new faces. Welcome to labor and delivery. Welcome to the oncology floor. Welcome to the clinic, wherever you are. We hope that you're getting welcomed into OBGYN, and we want to make sure that you know about a great resource in OBG First and the OBG Core.
So the OBG Core, as many of your senior residents will tell you, is absolutely free to all residents. So we wanted to make sure that you know about that. And then also, again, you also will get access for free if you are a resident to OBG First, as well as the labor and delivery book from the OBG project.
There are tons and tons of great resources through the OBG project. You can find them on their website at obgproject.com. But if you're interested in getting signed up for this premium product of theirs for absolutely free for all 4 years of residency, head over to our website, creegsovercoffee.com, check out the sidebar, and get signed up today.
All right, guys, welcome back. This is Fei.
This is Nick.
And this is
Creogs over coffee.
All right, guys, so today we are going to be doing an Espresso episode, and we're going to be very quickly talking about respiratory syncytial virus because it's pretty topical right now. So, Nick, what are our learning objectives for today?
Yeah, so we'll start off by reviewing what exactly respiratory syncytial virus, or RSV, is and why preventing it can be critical for newborn and infant healthcare, basically. We'll then discuss some recent innovations you may have heard about in RSV vaccination and a monoclonal antibody. And then finally, we'll understand current recommendations for both the RSV vaccine and the monoclonal antibody as it relates to kind of our care. So Fei, let's jump back. Well, I shouldn't lie and say that, but I really have not thought, admittedly, a lot about RSV since I was a medical student, I think. So maybe other people are like that too, but let's just bring it back. Medical school, residency, parenthood. What exactly is RSV?
Yeah, so like you said, RSV stands for respiratory syncytial virus, and RSV is a negative sense single-stranded RNA virus, and the name comes from the large cells that are known as syncytia that can form when the infected cells in our bodies fuse. And the reason we care about RSV is that, even though in someone like you or me or potentially older children, it just causes a mild cold-like symptom and most people will recover in like 1 to 2 weeks, infants and older adults are much more likely to develop severe disease that can require hospitalization. Most of the time, even for infants and older adults, these symptoms are just localized to the upper respiratory tract, so you kind of get some, those like cold-like symptoms, but then it can also lead to lower respiratory tract infections. And most children under the age of 2 will contract RSV due to some contact with others. And it's actually the most common cause of bronchiolitis and pneumonia in children less than 1 year of age. And this leads to 2.1 million outpatient visits, as well as 58,000 to 80,000 hospitalizations per year. And it also leads to 100 to 300 deaths among children less than 5 annually. So I'm sure that this is something that our pediatrician colleagues see a lot of, especially in RSV season, which we're about to head into. And we also know that specifically, those that are at risk for severe disease are patients like premature infants and infants less than 6 months of age, individuals with chronic heart or lung disease, those who are immunocompromised, and older adults, by which I mean those who are 65 and older. So I think, we are obviously talking about RSV. This is not something that necessarily affects our patients while they're pregnant, but certainly can affect their infants. But why are we discussing RSV now, Nick? What is bringing it to the forefront at this time?
I think we're about to see a lot of patients start asking us about it due to a couple of recent developments. The first of these is an RSV vaccine, which is really exciting. The FDA recently approved I'm going to butcher the pronunciation, the Palavizumab vaccine for RSV use in infants up to 6 months of age and for older adults. So that's just brand spanking new as of July 2023. And even more recently, as of August 21st, 2023, the FDA approves the RSV vaccine in pregnant individuals to prevent RSV in infants. It's approved for use between 32 and 36 weeks gestation in order for those antibodies to be able to cross the placenta and provide protection to the infant for up to 6 months of age. The CDC has not yet set recommendations about the vaccine, but we anticipate it will do so sometime around October of 2023, which is probably when you're listening to this podcast, frankly.
Yeah.
This is a bivalent vaccine. Just for some facts, it's comprised of 2 recombinant RSV fusion surface glycoproteins, and it helps protect against RSV A and B strains. There are 2 randomized trials that provide the data for this intervention. The first took place in pregnant patients, actually. It was 3,682 patients who were at 24 to 36 weeks. They were given the vaccine, and another 3,697 patients received a placebo vaccine. There were fewer medically attended severe lower respiratory tract illnesses in infants within 90 days of birth than those that received the vaccine, offering an estimated efficacy of about 81.8%. And then the confidence interval on that ranging from 40.6% to 96.3%. So really remarkable efficacy for a vaccine, particularly within those first 90 days after birth. There are also fewer medically attended severe lower respiratory tract illnesses within 180 days after birth, providing evidence of efficacy of close to 70% out to that 6-month mark. There's similar adverse events in both groups. However, in safety studies overall, the low birth weight and jaundice in infants occurred in a higher rate in the vaccine group compared to placebo. There was also an imbalance of preterm births in the 2 groups, with the vaccine group having about a 5.7 rate versus a placebo group of 4.7 rate. But the data is currently insufficient to really establish a causal relationship with the vaccine. So at this point, the current recommendation is to give after 32 weeks out on an abundance of caution, basically with respect to that preterm birth data, as that's still being sorted out. Now, in older adults, there was also a randomized trial of 18,000 adults at 60 years of age or older who were given the vaccine, and then another 18,000 who were given a placebo. And just to summarize this quickly, significantly fewer RSV-associated lower respiratory tract infections with 2 signs or symptoms occurred in the vaccine groups compared to the placebo group, making an efficacy of about 66.7%. And then there were significantly fewer RSV infections with 3 signs or symptoms in the vaccine group, so more severe disease in this case, 85.7% efficacy for preventing that more severe disease. There was higher rates of local reaction with the vaccine, 12% in the vaccine group versus 7% in the placebo group, as you might expect with multiple other vaccines as well. And there were similar rates of adverse events through about 1 month after injection in both groups. The FDA is currently requiring the company to conduct post-marketing studies to assess the risk of preterm birth and preeclampsia with respect to those pregnant patients. But again, pregnant patients and older adults are kind of the 2 targeted groups based on these randomized trials. And honestly, I think it's really exciting to see a randomized trial thinking about future health of a neonate taking place in pregnant women, a placebo randomized trial, Faye.
Absolutely. Yeah. We don't see that a lot right now.
Yeah. Additionally, though, there is another exciting development on the pediatric side, right?
Yes. So this is the RSV monoclonal antibody. So the FDA has approved the use of, and again, I'm going to butcher this name, Nirsevimab. The trade name is Beyfortus. And this is a long-acting monoclonal antibody for use to prevent lower respiratory tract disease due to RSV in infants and young children. And this was approved in July of 2023. The recommendations currently for Nirsevimab is that all neonates and infants born during or entering their first RSV season at less than 8 months of age may receive this antibody for prevention. And also children up to 24 months of age who remain vulnerable to severe RSV disease through their second RSV season can also get this. And this includes children who, for example, are immunocompromised. This is administered as a single IM injection. And the data behind this monoclonal antibody actually comes from 3 clinical trials. So in one trial, this was done on preterm infants, and they were born between 29 to 35 weeks gestation. Almost 1,000 received a single dose of nirsevimab, and about 480 received the placebo. And they found that those who received the monoclonal antibody, 2.6% experienced medically attended RSV lower respiratory tract infections compared to 9.5% of those who received the placebo. And so this was a risk reduction of 70%. And then in another trial of infants who were born at greater than 35 weeks gestation, so these were infants who were term or, very late preterm, almost 1,000 again received the monoclonal antibody, and almost 500 received the placebo. And in this case, again, the monoclonal antibody group had a 1.2% medically attended RSV lower respiratory tract infection rate compared to 5% of the infants who received the placebo. And this was a risk reduction by 75%. So again, pretty good. The final trial that was done was actually a randomized, double-blind, active, controlled, multi-center trial to prove safety. And they looked at the difference between nirsevimab versus Palavizumab. And again, I'm probably butchering both of these monoclonal antibody names. So Palavizumab is actually another monoclonal antibody, and it was used before to decrease severe disease caused by RSV. However, this specific antibody was only used in those children at high risk for RSV, including premature infants less than 35 weeks of gestation who are less than 6 months of age, children less than 2 years of age who required treatment for bronchopulmonary dysplasia, and children less than 2 years of age who have hemodynamically significant congenital heart disease. So this antibody that we have currently, Palavizumab, is one that's more restricted than the current recommendations for Beyfortus. So in this specific study, they showed that Beyfortus was essentially non-inferior in terms of safety compared to this older medication. So I think, with some of these new innovations, Nick, with these two things that are coming out this fall potentially, there are some lingering questions, right? So what are some of these things that, we need to continue thinking about?
Yeah, well, I think obviously the first is when will we be able to see these things and when we'll be able to counsel and use them. The monoclonal antibody should be available this fall per the FDA. So kind of, again, going into this very first season of RSV this fall, we should hopefully be able to take advantage of it, or the pediatricians, I should say, should be able to take advantage of it. Vaccines should also start to become available at doctors' offices and at pharmacies if the CDC approves the vaccine akin to the FDA, kind of in October time period, as we mentioned before. When you're thinking about the monoclonal antibody, again, you're thinking that this is going to be available probably in pediatricians' offices and in hospitals for after delivery. And so will probably be something that will become part of the newborn counseling from the pediatric side. Though depending on your involvement with that after delivery, you might be talking to your patients about it as well. The other piece, Fei, that is really interesting to think about just as, societal responsibility, I guess, is exactly the cost of these things.
Yeah. So, the big things that we always think about with monoclonal antibodies is that these types of medications tend to be expensive compared to some of our other types of medicines. And per the American Academy of Pediatrics, one dose of Beyfortus is $495 for both the 50 milligram and the 100 milligram doses. So almost $500 per dose. And per Pfizer, the RSV vaccine of Brisvo will likely cost somewhere between $180 to $270. So cheaper than, Beyfortus, certainly, and that does make sense. Usually vaccines are cheaper than monoclonal antibodies. But for reference, the pediatric influenza vaccine costs somewhere between $14 to $30. So certainly this is, on another scale of being expensive compared to some of the other vaccines that we give. And so I think going forward, it might be prudent to kind of look at, what are the societal benefits, obviously, of having these vaccines and the monoclonal antibody, but also what are the costs, and are we actually reducing costs by reducing hospitalization over the long run? All right, Nick, I think that brings us to the end of this Espresso episode. So once again, this is Fei.
This is Nick.
And this has been Creogs Over Coffee.
So guys, if you enjoyed the podcast today, head over to iTunes, Spotify, Google Play, whatever your podcatcher is, and give us a 5-star rating and review.
You can find us on social media, on Twitter at CreogOverCoff1, on Facebook and Instagram at CreogOverCoffee. And if you want to donate to the show, go ahead and go onto our Patreon at www.patreon.com/CreogOverCoffee.
We have show notes for this episode as well as all of our previous episodes and that Rosh Review question of the week on our website, CreogOverCoffee.com.
And if you have corrections for us, suggestions for the show, or just want to say hi, go ahead and email us at CreogOverCoffee@gmail.com.